Okay. Good evening, students. I hope I'm audible. So we'll just wait for a couple of minutes for everyone to join in. Please let me know here if you all are here. Good evening, Monirudya. Okay, great. So you're having good audio. We'll just wait for another 2-3 minutes so that everyone else can join in, and then we'll start our discussion. Okay. So before we start with our discussion, I want to speak to all of you for a few minutes. Now see, analyzing the oral surgery paper, no doubt the topics have remained the same, but the level of the questions or the way questions were asked, I would categorize them as difficult. Okay. The questions asked mostly were from either from recent articles or were mostly things that you go through during your post graduation rather than knowing at the undergraduation level. But my only advice to all of you would be, do not get disheartened. All right, INICET has happened, wo ho chuka hai, so that has passed away. Now what we have to concentrate on is NEET. NEET is the bigger picture. ठीक है? So I would say picture abhi baki hai mere dost, so we have to concentrate on NEET. Definitely we have to keep all of this in mind. The topics that were touched upon this time, the type of questions that were asked upon this time. So now we have to take that also into consideration. But my only suggestion and only advice would be, please do not get disheartened. Don't be hard on yourself. All right. The oral surgical part was a little more difficult as compared to the other questions or other questions from other subjects. All right. So that is fine. That has happened. We now have to travel ahead. All right. Second thing is, in case if you feel the question has not been recalled correctly or you have to add in something, you can either write down in the comments now, or you can message me on WhatsApp in the group later, or even if someone has written down the questions separately after coming from the exam, they can make a document of that and also send it to me on the WhatsApp or directly message it to me as well, so that once we are doing our further revision sessions, we have a complete set of questions, and then we can again discuss if something needs to be changed or corrected. We can do that also. All right. So we will start off our session for INICET recall. I am starting with a relatively easier question first. So the question says, which of these types of condylar fractures have the highest chance of ankylosis in skeletally immature patients? All right. Now we will attempt this in a way that I always tell you to attempt. All right. We will just do a practice of how we will be attempting it in our exam. So the question is asking, your first point to be noted is highest chance of ankylosis. Alright, in skeletally immature patients. So skeletally immature patients can be infants, it can be children, and most importantly this says skeletally immature. That means pre-pubertal, where the epiphyseal closure has not taken place. Pre-pubertal age group. Alright, this is what this question is trying to ask. Now coming to the options. All condylar fractures, definitely this is not the answer. Subcondylar fractures, definitely this is not the answer. Green stick fractures, definitely this is not the answer. Now we have option D remaining, that is dicapitellar fracture. This is, I understand this is a new term for you all. Now dicapitellar is the other name given for condylar head. Alright. Dicapitellar is the other name for condylar head. So here I would also like to emphasize, even if you're having a tough exam, or even if you're encountering tough questions, I would suggest that you do not panic. You see every question in the best possible way. Try to attempt it. Try to rule out. If you do not know, try to use whatever knowledge you have or whatever you studied up till now to rule out your answers based on your knowledge or the notes that have been provided to your theory given. See, nowhere in my notes I've mentioned all condylar fractures. Nowhere it is mentioned subcondylar fractures undergo ankylosis, and green stick fracture also do not undergo ankylosis. When I was telling you about the burst theory, if you go back to the notes and revise why there is more chances of ankylosis in children, when I was telling the burst theory, there I have said that due to a prominent head, alright, and absence of condylar neck. So with that knowledge, some things can still be attempted. Okay. Alright, now we'll go on to the next question. So here I'll just mark this in a different color so that when you come back to the video revise, you have the answer. Dicapitellar fractures is the answer. Alright. Now, coming to the next question. This question says Manson's subunit principle is applied to which of the following fracture management? Now, see, this is actually a difficult question, and we studied this in our post-graduation. I will just explain what is Manson's subunit principle, what is happening over there. So this is a difficult question. So we had a clinician, we had a surgeon, Manson. In 1999, for panfacial fractures, he gave certain guidelines for their management. Now first let us understand what is happening in a panfacial fracture. In a panfacial fracture, one or two or more than two bones of the bodies are fractured. The midface will be fractured, the mandible will be fractured at multiple sites, there might be a frontal sinus fracture, there will be a palatal fracture, a ZMC fracture, maybe arch fracture, maybe Lee-Foot level fracture. Okay, so there will be multiple fractures. That is known as a panfacial fractures. Good evening, Deepa. That is a panfacial fracture. Okay. Now, when we are looking at a face, we basically talk in terms of three things when we are reconstructing the face. Alright. We have to look at the facial width. We have to look at the facial projection. Projection is nothing but some authors also mention the projection as a depth. This dimension. Alright. This dimension. And the facial height. Alright. And the facial height. Alright. Fine. So this, our aim is to restore these dimensions in a panfacial fracture. Our aim is to restore these dimensions. So this was the article given by Manson, subunit principles in mid-phase fractures, the importance of sagittal buttress, soft tissue reductions and sequencing treatment of segmental fractures. You don't need to go into the details of this article. Whatever is required from this article I have listed down below, so we will write down. Now, important things. There are certain buttresses of the facial skeleton, horizontal buttress and vertical buttress. Alright. Now, what are these buttresses? These buttresses are the lines along which the force, if the facial skeleton undergoes a force, along these lines the forces are transmitted, and these being stronger bones, buttresses are stronger than the surrounding bones, so they try to keep the facial skeleton stable, or they try to keep the facial skeleton, or they try to resist the force. Alright, so these are your facial buttresses. Alright, just keep this list with you: horizontal buttresses and vertical buttresses. This can also be asked as a question. Horizontal and vertical buttress. Alright, so these are the areas along which forces are transmitted, and they try to keep the skeleton intact, or they try to stabilize the facial skeleton during the event of a force or an injury. Now, this picture I have picked from Manson's article. So what basically Manson did, once he said that if the entire face is fractured, we have to know from where to start and where to stop for our reduction and our reconstruction. So he divided this. This is not a very clear picture because this is a very old article. Alright, but I'll just zoom out. So he divided the face into subunits: superior orbital frame or frontal bar, central upper face, lateral upper face, maxillomandibular block and vomer. Fine, this is what it is. Now we will just have a look. So we now know what is buttress. Now our aim is to write down a few points. The aim is to restore. The aim is to restore width, projection and height. Alright, aim is to restore width, projection and height. So the sequencing. We now come to the sequencing. Okay. Or we'll do one thing, we'll write it on a new paper. Alright. Alright, sequencing of pan facial fractures. अब मैंसन ने क्या किया, उसने सब यूनिट्स में डिवाइड किया. तो उसने बोला कि हम दो सीक्वेंस फॉलो कर सकते हैं. वो दो सीक्वेंस क्या है? बॉटम अप, इनसाइड आउट, ओके, एंड टॉप डाउन, आउटसाइड इन. ठीक है. So this is something you really study at a postgraduate level. Alright. So very layman terms, just understand. Bottom पहले नीचे से शुरू किया प्लेटिंग, नीचे से ऊपर गए, और inside from the central area you come towards the outside. Alright, that is your sequence of which site you will manage first or how your plating will go. Alright, the second sequence is top down, that is ऊपर से नीचे है, and outer plating पहले करी, then central की तरफ गए, that is your palate and all of that. Alright, now bottom up, inside out का sequence I have given to you before also on the WhatsApp group, but we'll write down again. So here it is, repair palatal fracture, alright, followed by IMF or MMF. Then you address mandible fractures. Then after addressing mandible fractures, in mandible only, after that you address condylar fractures. Then you address frontal sinus. Then NOE complex. Then you do the repair of ZMC along with his arches if the arches are also fractured. And then you repair maxilla. That means you do the Leafort levels, and in the end you do the Leafort 1. At last you do the Leafort 1. Okay. Now the other sequence, top down, outside in. That is, you do the frontal sinus first. Repair of ZMC plus arches. NOE complex, that is naso-orbito-ethmoidal complex. Repair of Leafort's levels plus mid-palatal split. Followed by maxillomandibular fixation, followed by condyle, followed by other mandibular sites. ठीक है, ये sequencing है. Now let me tell you, in this, if you've missed out you can come back and write again. Okay, abhi samajh lo. In this sequence, no sequence is superior to the other. No sequence is superior to the other. It depends on surgeon's preference, his or her experience, and whatever results they were able to achieve. Alright. But the advantage of bottom up, inside out is that you achieve better functional occlusion. Alright, so some authors say you achieve better functional occlusion with bottom up, inside out, and some authors say ये वाले sequencing के साथ we need lesser weeks of maxillomandibular fixation, whatever, but they are not superior to each other. Alright, but preferred is bottom up, inside out. Okay, so this is your sequencing. You have to remember this. So they have sequenced this according to the Manson ने जिस सब यूनिट्स में डिवाइड किया था फेशियल स्केलेटन को, उसके अकॉर्डिंग उन्होंने ये सीक्वेंस दिया है. He has given 2 sequences. Alright, fine. We will go back to our questions now. So the answer here is Manson's subunit principle is applied in which of the following fractures? The answer is a panfacial fracture. Alright, panfacial fracture. This is the answer. Okay. Now we'll see our next question. A patient presents with deviation of chin to the left side which is painless. What would be your diagnosis based on the following radiographs? So you have just 2 important information from this question. One is deviation of chin to the left side and painless. Alright, so I would also like to tell you we don't have the exact images. So I could find, I think in the exam it was a right-sided this thing, no? Right-sided pathology was given in the exam if I'm not wrong. Fine. So now we had 3 radiographs. Alright. Just zoom out. We had 3 radiographs and the right condyle had some growth kind of a thing which was going medially. Okay, and there was another image on which there was a yellow spot. There was a yellow spot on an image, and there was this image on which there was this in the lateral view. I think, if I'm not wrong, it was lateral or maybe any other view. There was a little darkened spot in the TMJ area. Okay, now see, if you see the first image, this one, alright, it is definitely not looking like ankylosis. Alright, there's a very clear path between the glenoid fossa and the, what do you call, the condylar head. The anatomy is sort of maintained. Alright, एक clear path है, joint space intact है. Alright, otherwise there would be some, if it would be ankylosis, there would be some haziness in the joint space or some obliteration of the joint space, even if it is fibrous ankylosis. Some distortion of joint space would be there. Alright, and there's another image which was given to you, that was of a technetium 99 scan or a SPECT scan. I'll just explain all of this to you, on which there was a bright yellow orange spot. Alright, so this is a nuclear imaging technique. Fine. So now let's see painless deviation of chin to the right side. Let us first see our options. What all we can rule out without having any knowledge. Alright. Now, osteochondroma, okay, we might not know anything about. ठीक है. Right condylar fracture. Fracture कहीं नहीं दिख रहा है image में, तो fracture we have ruled out option P. TMJ dislocation, again we cannot see any TMJ dislocation in the image. Condyle is nicely sitting in the glenoid fossa, so this is also ruled out. Okay. Now there is confusion between osteochondroma and condylar hypertrophy. We will first see what are a few points regarding osteochondroma of the TMJ. तो osteochondromas facial skeleton में बहुत rarely दिखता है. Alright, it is a rare entity of the facial skeleton, and in facial skeleton, even if it is present, it is mostly seen in the condyle or the coronoid process. So we'll write down a few points. It is a rare, slow growing, benign tumor. Okay, some people also believe that since it has chondroma, cartilaginous tissue also in it, it might be developmental also. So it is some, that sort of discussions are also present. Alright, now important features. Unilaterally enlarged condyle with exophytic growth. ठीक है, unilaterally enlarged condyle with exophytic growth. Fine. Facial asymmetry. So there is deviation to the opposite side or contralateral side. Okay. Then after that there is decreased or limited mouth opening. Then we have, it is painless. So pain is a rare feature in this. Okay, pain is a rare feature in this site. So mostly anteromedial aspect of condyle. Anteromedial aspect of condyle is involved. और इन दोनों में से चूज करना हो तो मीडियल साइड पे ज्यादा दिखता है एज कंपेयर टू एंटीरियर. ओके, नाउ देयर इज क्रॉस बाइट contralateral side and open bite on the ipsilateral side. Alright, so these points are important. अब next question में occlusion की photograph दे देंगे. Okay, so now coming to the imaging part. You can get a OPG done, you can get a CT done, you can get a MRI done. अच्छा, MRI से हमें क्या पता चलता है? It helps evaluate the thickness of cartilage cap. Osteochondroma है ना, तो cartilage part होगा, तो cartilage part का thickness you can determine from the MRI. Okay, now technetium 99 MDP. Alright, write down, I'm writing the full form. Technetium 99 methylene diphosphonate. Technetium 99 MDP, that is methylene diphosphonate. अच्छा, ये क्या है? ये एक रेडियो एक्टिव ट्रेसर है. ऑलराइट, तो ये इंट्रावीनसली इंजेक्ट कर देते हैं. उसके बाद यू सब्जेक्ट द पेशेंट टू अ स्कैन. ऑलराइट, सो wherever the bone metabolism is altered or where there is something active happening in the bone, it will shine like a bright hot spot, that yellow orange color. So increased tracer uptake will show you a hot spot. That hot spot is nothing, वो जो एग्जाम में वो येलो ऑरेंज जैसा एक स्पॉट था एकदम ब्राइट, दैट इज योर हॉट स्पॉट. ऑलराइट, यू कैन गेट अ whole body SPECT, that is single photon emission CT. ये क्यों करवाते हैं? To rule out osteochondromas in the entire skeleton. Alright, so these are the imaging modalities. Now why to rule out osteochondromas of the entire skeleton? क्योंकि ये osteochondroma जो है इसका predisposition ज़्यादा है for longer bones for other regions of the body. इसका predisposition facial skeleton में कम है. It is relatively rare in the facial skeleton. एंड फेशियल स्केलेटन में भी अगर ये होता है तो इसका प्रीडिस्पोजिशन है कॉर्नोइड और कॉन्डाइल में प्रेजेंट करना. फाइन, नाउ वी विल गो बैक टू आवर क्वेश्चन. क्या दिख रहा है? एक मीडियल साइड से कॉन्डाइल में ग्रोथ है, मीडियल एस्पेक्ट से जो ग्रोथ है और मीडियली ही जा रही है, मीडियल एस्पेक्ट ऑफ कॉन्डाइल से, यहां से जहां मैंने मार्क किया है वहां पे ग्रोथ है, वहां से कुछ एक्सॉस्टोसिस टाइप का हुआ है एंड इट इज गोइंग मीडियली. फाइन, देयर इज अ हॉट स्पॉट हियर ऑन द स्कैन. फाइन, एंड वी हैड deviation of chin to the left side and painless. So I just told you Yes, I'll just explain more, Nirutya. I just told you painless होता है, contralateral side deviation होता है. So the answer here would be osteochondroma. Now to differentiate condylar hypertrophy, let me tell you, जो condylar hypertrophy होती है उसका न्यूक्लियर मेडिसिन आपका टेक्नीशियम 99 MDP और स्पेक्ट पे कोई ट्रेसर अपटेक नहीं होता है. नो ट्रेसर अपटेक. ऑलराइट, किसका अपटेक होता है? ट्रेसर अपटेक कॉन्डाइलर हाइपरप्लेजिया का होता है. प्लीज रिमेंबर, कॉन्डाइलर हाइपरप्लेजिया में ट्रेसर अपटेक और हॉटस्पॉट होता है. ऑलराइट, हाइपरट्रोफी एंड हाइपरप्लेजिया, बिकॉज जो कॉन्डाइलर हाइपरप्लेजिया है वो एक्टिवली ग्रोइंग कॉन्डाइल है. वो ग्रोइंग कॉन्डाइल है इवन आफ्टर द ग्रोथ स्पर्ट हैज स्टॉप्ड और इट हैज सीज्ड. ठीक है, उसके बाद भी कॉन्डाइल इंक्रीज कर रहा है साइज में. तो क्या होगा? वो कॉन्डाइल एक्टिव है, एक्टिवली ग्रो कर रहा है, जो हाइपरप्लेजिया वाला कॉन्डाइल होगा. इसीलिए उसका कॉन्डाइलर रीजन में ट्रेसर अपटेक होगा. ऑलराइट, fine. So yes, the last point regarding SPECT that I had just explained, I want to say that जो osteochondromas होते हैं वो they have a predisposition for occurring in the rest of the regions of the body, rest of the skeleton apart from the facial skeleton. Facial skeleton में इसका presentation rare होता है. ठीक है, अगर इसका प्रेजेंटेशन रेयर होता है तो भी मोस्ट कॉमनली फेशियल स्केलेटन में इट इज फाउंड इन द मैंडिबल, कोरोनोइडर, कॉन्डाइलर रीजन. बट अगर आपको ऑस्टियोकॉन्ड्रोमा डिटेक्ट हुआ है फेशियल रीजन का, तो यू हैव टू रूल आउट इफ देयर इज एनी अदर ऑस्टियोकॉन्ड्रोमा प्रेजेंट एल्सवेयर इन द स्केलेटन. सो यू गेट अ होल बॉडी स्पेक्ट स्कैन डन. तो वो आपका होल बॉडी में कहीं और कॉन्डाइलर ऑस्टियोकॉन्ड्रोमास होंगे तो दे विल पिक अप दैट. All right, is that clear? Doubt is clear? Fine, we'll move ahead. In pediatric patients, the next question, in pediatric patients in comparison to adults, all of these are reasons for increased chances of TMJ ankylosis except. So this was a relatively easier question. Bulbous condylar head with increased marrow content. Yes, this is one of the reason. मेरा burst theory वाला lecture याद करो. तो there is, I said there is shorter condylar neck और absent condylar neck. तो head बड़ा होता है, सारे forces head पे transmit होते हैं. मैंने diagram में भी अच्छे से बनाया था. High osteogenic potential, yes, this is there for ankylosis. Increased lateral pterygoid traction, no. And short mandibular condylar neck, yes, this is also one of the reason. Short neck होता है तो सारे forces head को transmit होते हैं. So the question was asking except which of this is not a reason for increased chance of ankylosis there, that is increased lateral pterygoid traction. ऐसा कुछ नहीं होता pediatric patients में. Okay, that is why this is the answer. So this question is doable. Fine. We will come to question 5. All are true about Ludwig's angina except. Fine. Tracheostomy is the only resort for intubation. Yes, sometimes Ludwig's angina में आप फाइबर ऑप्टिकली इंट्यूबेट कर सकते हो, बट कभी कभार अगर यहाँ एडेमा बहुत ज़्यादा है, all right, because it is a browny swelling of the submandibular, submental region, sublingual region. So because of being this area being swelled up, there is a huge swelling here. So due to this, there can be swelling. Due to this, the anesthetist may not be able to visualize the vocal cords to intubate the patient either through fiber optic. Normal intubation तो हो ही नहीं पाएगा इस patient का, but fiber optic, awake fiber optic intubation भी possible नहीं होता है. So we have no other option but to do a tracheostomy. but to do a tracheostomy. So the option B says bilateral involvement of submandibular, sublingual and submental spaces. Yes, this is also true. It is a surgical emergency as airway is at risk. Yes, some people actually come with shortness of breath, decreasing saturation. So yes, it is an emergency. Option D is intravenous antibiotics, rest and culture sensitivity testing is the norm. No, this is not your first line of treatment. Alright, koi rest nahi, it is an emergency. Ludwig's angina is always an emergency. There is no rest, no culture sensitivity. These all things have to be done later. First, you have to drain, relieve the patient's symptoms, and then you have to, yes, intravenous antibiotics, you can maybe just, if you're planning an emergency OT, say in another 15 minutes, 20 minutes, you can give one shot of antibiotic to the patient. But that is not the mainstay of treatment. Rest, though definitely not. Culture and sensitivity, once you have drained, you can send that pus that you have obtained for culture and sensitivity. So these are the steps either that are happening concurrently or are happening later. But these are not the first steps. So your answer is intravenous antibiotics, rest and culture sensitivity. Alright, this is your answer. Because the question is asking except. It is asking you to identify the false statement. Fine. Now, coming to the next question, which of this is not a treatment alternative for enucleation in odontogenic keratocyst? Okay. Now the options: cornoid solution, yes. Peripheral osteectomy, yes. So the confusion was between 5-fluorouracil and preoperative radiotherapy. Now, this 5-fluorouracil is not mentioned in the books. So this is a new thing, new concept, that cornoid solution. What is cornoid solution? Chemical cauterization, right? What is it? It is an adjunctive procedure. And why were we using cornoid solution? To decrease the recurrence. Hai na? This is what also I had told you in the class. So, but cornoid solution, remember we had studied cornoid solution, farmers, type 1, type 2, then modified. Kyun modify kiya? Because uska carcinogenic potential hai. All these things, it is toxic to the nerve. All of these things. So now what is happening? Authors are studying, clinicians are studying other agents that we can use as an adjunctive, which may be at par or which can work in a similar fashion like cornoid solution. तो एक जो agent study हो रहा है वो है 5-fluorouracil. So again, this information has been found in articles. So this was one article I found out. This is the highest level of evidence. So it was comparing 5-fluorouracil versus modified cornoid solution for treatment of OKCs, a systematic review and meta-analysis. Now I'll just give you a few points for use of 5-FU in odontogenic keratocyst. Fine. So तो इसके एडवांटेजेस क्या हैं? Easily available. Fine. It involves a simpler technique. I'll tell you the technique also. Less neurotoxic. हमें neurotoxicity से why are we concerned? Because we want to preserve our inferior alveolar nerve. We do not want any agent to be toxic to the nerve. Alright, and lesser recurrence. ठीक है, ये in comparison to, ये इसके अपने advantages भी हैं, in comparison to भी modified cornoid solution भी ये इसके advantages हैं, both ways. ये इसके अपने एडवांटेजेस भी हैं, और अगर इसको कॉर्नर्स से कंपेयर करो तो भी ये उसके एडवांटेजेस हैं. फाइन. नाउ द टेक्निक. यू टेक अ रिबन गॉज. क्लिनिक्स में देखी होगी कि ऐसे पतले से स्ट्रैप की तरह एक बहुत बड़ा रोल्ड गॉज आता है, एक रोल आता है. ऑलराइट, दैट इज अ रिबन गॉज. सो रिबन गॉज coated with 5% 5-fluorouracil is packed in the bony cavity and removed after 24 hours. Alright, and removed after 24 hours. So what are we doing? We are giving topical 5-FU. ठीक है, तो हमने क्या किया, इन्यूक्लेशन किया, ठीक है, पेरिफेरल ऑस्टेक्टमी करी एंड एक गॉज लिया. यू रिमेंबर आई टोल्ड दैट जब हम मार्सिपलाइज करते हैं तो वी आर पैकिंग दैट गॉज विद डिफरेंट मेट्रोजेल पेस्ट, सोफ्रामाइसिन, बिप पैक. हम जब मार्सिपलाइज कर रहे थे तो वो उस Okay, am I audible now? Audible now? I'll explain the last part again, but first confirm if the audio is fine. Can you all hear me now? Okay, great. So I'll explain this use of 5FU in OKC again from the starting, so that whosoever has missed out. So I was talking about use of 5FU in, yes, I'm explaining, don't worry. So we were talking about use of 5-fluorouracil in the treatment of OKC. Now, so this is a relatively newer concept because authors and clinicians are looking for alternatives to Carnoy solution. Because if you remember, when I told you in the class, I told you 3 types of Carnoy solution, and we had modified the Carnoy solution because of its toxicity and carcinogenicity. So new options are being explored. All right. So what is the advantage of 5-fluorouracil? The advantages are that it is easily available. It involves a simple technique. It is less neurotoxic. Why are we bothered about neurotoxicity? Is because most of the times we will encounter the nerve in our enucleation procedure. All right, and or we will be working in close relation to the nerve. And the fourth advantage of it is that it has been seen that it causes even lesser recurrence. All right, so ये 5-fluorouracil के अपने advantages तो हैं ही, in comparison to modified Carnoy solution भी ये इसके advantages हैं. Okay, now the technique. I was talking about the technique. तो technique में क्या करते हैं? पहले हमने enucleation किया, peripheral osteectomy करी बर्स से या क्यूरेट से, ठीक है. उसके बाद जो बोनी कैविटी बची, we take a ribbon gauze. You must have seen in your clinics there is a small strap like gauze, एक लंबे रोल में आती है पतली एकदम strap like gauze, that is called as a ribbon gauze. So उस ribbon gauze को लिया और 5% 5-fluorouracil में उसको पूरा कोट किया अच्छे से. And now what we are doing, we have that bony cavity, we have nicely packed this gauze inside that bony cavity, and we make sure that the 5-fluorouracil is in contact with all the surfaces of the bony cavity. Okay, what we are doing now, we are closing our soft tissue flaps. जो हमने म्यूकोपेरियास्टल फ्लैप उठाया था वो हम क्लोज कर रहे हैं, बट क्लोज करने का एक टेक्निक है. वी आर क्लोजिंग बट एट द एंड, or where we have given our incision, at the end we're just leaving 1 or 2 centimeters open, and from there we will leave this gauze hanging outside, that is in the patient's oral cavity. What we will do after 24 hours, we will take a artery or we will take any instrument, we will hold this hanging piece of gauze and remove that entire gauze. So you have to, your basic aim is to keep 5FU in contact with the bony cavity for 24 hours, and uske baad you remove that gauze. Alright, this is the technique. So आप क्या कर रहे हो, आप topical application कर रहे हो 5-fluorouracil का. You're doing topical application of 5-fluorouracil. Has everyone understood? Has everyone understood? Monirudya, Deepa, is it clear? We can use it with marsupialization also. We can use it with marsupialization also. It is not that we we don't use it with marsupialization. But if you remember, OKC has higher chances of recurrence, right? तो हम marsupialization कम प्रेफर करते हैं. अगर हम marsupialization प्रेफर भी कर रहे हैं OKC में, तो हम marsupialization के बाद we will eventually, when the cavity has reduced in size, we will eventually prefer enucleation. That is marsupialization followed by enucleation, PASH 2 procedure, है ना? तो that is why it can be done with marsupialization also, but in that the lining would still be inside the oral cavity, the OKC lining, and we prefer not to leave OKC lining unless absolutely necessary inside the patient's oral cavity, because OKC has high chances for recurrence. All right. So, which of this is not a treatment alternative for enucleation in odontogenic keratocyst? Carnoy solution, yes. Peripheral osteectomy, yes. 5-fluorouracil, yes. तो जो हम नहीं यूज करते हैं वो है प्री ऑपरेटिव radiotherapy. Alright, so this is the answer. In fact, radiotherapy is not used for OKC, whether pre-operative or post-operative. Alright. Now, so this question was also relatively difficult, because this is also something that we learn and do it on patients once you're doing your PG. So when a patient with panfacial trauma underwent the following test, identify the name of the test. Okay. So we will first see these tests and then we will come back to the question. I also have a few visuals, but first we'll write what all tests we can do clinically to determine a NOE fracture. All right. Please write down clinical diagnostic test. For NOE fractures, that is naso-orbitoethmoidal fractures. Fine. So the first one is bowstring test. So the lateral canthus is pulled laterally. The lateral canthus is pulled laterally, and the medial canthal area, MCT's medial canthal area, is palpated to detect. Just write down the test. I'm going to explain every test one by one. Palpated to detect movement of fractured segments. Okay, just write down. I'm going to explain. So the second one is furnace test. Alright, furnace test. So this involves grasping of overlying skin of medial canthus with small tissue holding forceps, and lack of creasing or lack of resistance by underlying bone, lack of creasing or lack of resistance of underlying bone signifies a fracture. Alright. Now the third is by manual palpation. By manual palpation. Now there's something instrument known as a Kelly clamp. Zaruri nahi hai Kelly clamp, you can take any instrument and placed high up into the nasal cavity, high up into the nasal cavity, directly beneath the medial canthal tendon, and you do a gently lifting motion. I'll just explain on the visual. अभी बस लिख लो, gently lifting motion, and with fingers palpate the tendon. Just write down. I'm going to take you to the visuals and we will understand. और तो जो इमेज में दिख रहा है वो है बोस्ट्रिंग टेस्ट, बाकी के हम देखते हैं. फर्स्ट वील सी बोस्ट्रिंग टेस्ट. तो बोस्ट्रिंग टेस्ट में क्या कर रहे हैं? ऑलराइट, यू keep one eye here on the lateral canthus, or you keep one finger here on the lateral canthus, or you just pinch the lateral canthus like this. Okay, and when either you do this motion or either when you pinch the lateral canthus towards the outside, you take another finger and keep it on the medial canthus. All right, so when you do this, you just do it for yourself. You will feel this canthus is the finger on the medial canthus. You will feel resistance over here. You will feel resistance over here. Just do this on yourself. You will feel resistance. Okay. But in case of a fracture, this resistance would be lost. You will feel either the fracture fragment moving here at the medial canthus. You will feel either crepitations here at the medial canthus, or you will be able to palpate that the canthal attachment is not present, or it is lost, or there is loss of resistance. Okay, this is a bowstring test. All right, fine. Now coming to the furnace test. Furnace test I did not get any picture for, पर क्या करते हैं furnace test में, you take a small tissue holding forceps and you try to hold the medial canthus with that. All right, again you will feel either loss of resistance or यहाँ पे creasing जो है that will be lost. All right, so that means there is an underlying fracture. Now bimanual palpation. Bimanual palpation. Just look at this. I'm zooming out. You insert any instrument. Mostly book में लिखा हुआ है Kelly clamp. तो वो एक आर्टरी की तरह ही इंस्ट्रूमेंट होता है. You just take any instrument that you can insert in the nasal cavity high up, and you direct that instrument up till the level of your medial canthus, and you try to direct it beneath the medial canthus, and उसको lifting motion में instrument को use करो, and put your 2 fingers here at the medial canthus and palpate. You will be able to palpate a fracture. Fine. These are the 2 things. I think with these visuals it should be clear. Bowstring test, furnace test, and bimanual palpation. Okay. So these are the 3 clinical diagnostic tests of a NOE fracture, naso-orbitoethmoidal fracture. Fine. Now, coming to question number 8, what is the appearance of articular disc of TMJ in an arthroscopic view? So I do not know why this question was there at an undergraduate level exam. So TMJ arthroscopy is something जो PG में भी नहीं देखा जाता है. TMJ arthroscope is something which is practiced by maybe handful of very senior surgeons in India. So what is TMJ arthroscope? If you all must have heard about knee arthroscopic surgery, shoulder arthroscopic surgery. So what is done in a TMJ arthroscope? You have a arthroscope, 2-3 ports होते हैं. You just, what you do is, it is a minimal invasive surgery का technique. You puncture holes here and around the TMJ. You insert, one port is for the camera, one port is your maybe cautery or something, and one port is for your it is either a scissor kind of a thing or a clamp kind of a thing, so there are different things. Even I had to go through a lot many articles to come at a conclusion for this question. So it is a minimal invasive procedure for the TMJ and the disc. Now it is asking you the appearance of articular disc of the TMJ. So just remember, the answer to this question is, so a normal disc कौन सा होगा जिसमें कोई एडिशन नहीं है, कोई टीयर नहीं है, कोई एबनॉर्मैलिटी नहीं है, कुछ नहीं है ना. तो even if we look at the options one by one, red due to hyperemia and high vascularity, no. कॉटन वूल अपीयरेंस, नॉर्मल चीज का यूजली कम ही कॉटन वूल अपीयरेंस होता है. ऑलराइट. शाइनी वाइट and transparent with condylar head visible through it. We know that the disc is not transparent also. So any disc which is disease free, which is pathology free, which is normal, is going to be shiny white. Alright, it is going to be shiny white. Fine. So this is that answer to this question. Now we'll come to our next question. Which of the following is seen in the patient below who was recently operated for TMJ surgery? तो ये एक इमेज बेस्ड क्वेश्चन था जिसमें शायद ये था कि the patient had a facial nerve palsy kind of a picture. Now since we have not been able to figure out the actual image, I am giving you a few tips for the presentation of facial nerve paralysis, terminal branch especially, और उसका क्लिनिकल प्रेजेंटेशन कैसे दिखेगा ताकि आप कोई फ्यूचर में क्वेश्चन आए, यू पीपल कैन आंसर. मोर देन ओरल सर्जरी, दिस इज मोर ऑफ अ anatomy कम ओरल सर्जरी मिक्स kind of a question. ठीक है, तो we all know there are 5 terminal branches of our facial nerve: temporal, zygomatic, buccal, marginal mandibular, and cervical. Fine. And I always give a mnemonic to remember these 5 branches in their order from superior to inferior. तू ज़्यादा बकवास मत कर. Alright. Temporal, zygomatic, buccal, marginal, and cervical. So the mnemonic that I always give for this is, and they are present like this. Alright. This is how the terminal branches are present. In this fashion. Fine. So the temporal branch is supplying the frontalis muscle. Alright. The orbicularis oculi. Okay. And corrugator supercilii. Fine. The zygomatical branch is supplying the orbicularis oculi. The buccal is supplying the orbicularis oris and buccinator. Fine. Marginal is supplying the mentalis and depressor anguli oris, and cervical is supplying the platysma. ठीक है, roughly they supply other muscles also, but roughly I'm just giving you they supply these muscles. Now just see what will happen if the temporal branch is paralyzed. If the temporal branch is paralyzed, there will be loss of wrinkling over forehead. Fine. There will be drooping of eyebrow. Okay. If zygomatic branch will be disrupted or there will be an injury, there will be inability to close eye. Fine. And drooping of eyelid. Buccal branch में if there is a issue, so there will be loss of nasolabial fold और crease. मतलब वहां का fold flatten out हो जाएगा, दिखेगा ही नहीं बिल्कुल भी. Fine. Drooling of saliva bar food and drooping of angle due to the buccal branch. Now, due to the marginal mandibular branch, there will be drooping of angle of mouth. There is certain overlaps also, I'll tell you why. And asymmetric smile. Fine. And due to cervical, there will be asymmetric lower lip. ठीक है. So these are the muscles supplied by these terminal branches, and this is the sign or symptom when that particular branch is damaged or injured. Now what happens is, ऐसे नहीं होता कि ये पांचों ब्रांचेस ऐसे अलग अलग प्रेजेंट है. इन ब्रांचेस के बीच में भी आपस में क्रॉस कनेक्शंस होते हैं. Alright, so you can have overlapping features also. You can have maybe drooping of angle due to damage of buccal branch. You can have drooping of angle due to damage to marginal mandibular branch. So my advice to you is, remember this table and try to answer your question accordingly, according to the image given. Whatever you can see, loss of forehead wrinkles है, eyebrow droop कर रहा है या eyelid droop कर रहा है, inability to close eye है. Due to buccal branch, the patient will not be able to blow also. Patient will not be able to hold air. Unable to hold or blow air in mouth. ठीक है. So you now have this comprehensive table. According to this, you can answer the question. Whatever image was given to you in the exam, or whatever image might be asked to you in the future. Alright, so we will so the answer to this question will be dependent on what the image is. Okay, on what the image is. So I am not pointing any answer to this question over here. Alright. Now coming to the next question regarding Bupivacaine, which of the following statements is not correct? I think there was some issue regarding the recall of this question, because all the statements that are written over here are not correct. Either it was except or something, I am not sure. But all the statements mentioned here are incorrect. So I'll give you a few points regarding bupivacaine. Again, a question can be answered based on what would have been the correct options. If anyone can recall the correct options, please let me know so that we can update the question bank. Alright, now a few points regarding bupivacaine. Quickly, just we'll do a few points. So it is an amide, not an ester. Fine. It is less toxic than lignocaine. So it is 4 times less toxic, okay? 4 times less toxic than lignocaine. Slower onset, that is 6 to 10 minutes. Okay. Long acting, more than 180 minutes. Used for post-op pain relief, post-operative pain relief. Alright. इसका कोई टॉपिकल वर्जन अवेलेबल नहीं है bupivacaine का. Half life is 2.7 hours. Not recommended for Acha. Now there are two versions. US में it is said it is not recommended to children below 12 years of age. And in Canada they say it is not recommended for children less than 2 years of age. But अगर कुछ consider करना है दोनों numbers में से, just remember it is not recommended for children below 12 years of age. Alright. Now, most important contraindications. So these contraindications were not given straightforward anywhere. So certain companies which are manufacturing this bupivacaine in the US, I found a few contraindications on their website. Alright, the manufacturers of this bupivacaine in the United States. So the contraindications are cardiac arrhythmias, alright, or reduced cardiac output. Fine. In septicemia, in severe hemorrhage or hypotension or shock, it is contraindicated. In known hypersensitivity, अगर कोई bupivacaine से known hypersensitive है तो उसमें ये ड्रग एडमिनिस्टर नहीं करना है. And intravenous regional anesthesia, that is Bayer's block. Now what is Bayer's block? When you are doing a surgery on the extremity, तो क्या करते हैं, ब्लड सप्लाई को मोमेंटरली स्टॉप करने के लिए टॉर्निक्यूट प्रेशर बैंडेज बांधते हैं यहाँ पे फोरआर्म पे, एंड वीनस लाइन में they inject anesthetic agent to operate on the hand or the extremity. So it is contraindicated for this kind of a block also. Alright, it is contraindicated for this kind of a block also. Fine, so these are the contraindications. These are the contraindications. Now coming to our last question. So coming back to this question regarding bupivacaine, which of the following statement is not correct? Not correct तो A, B, C तीनों है. Either the question was different or there is some problem with the recall. If any one of you can help me update this question, please let me know. We will update it and we can always discuss it later. Now coming to question, last question for our discussion today. Which of the following is used for testing visual acuity? I think कुछ ऐसे options थे, monocular vision, Jagger chart, Hess chart. Again, we do not have the complete set of options. And so I'll just tell you 3 things which I have mentioned before also. Alright, before we see this visuals, we'll just write down. तो हेस चार्ट ये मैंने ग्रुप पे भी बताया था. हेस चार्ट इज फॉर रिस्ट्रिक्शन इन गेज. ठीक है. स्नेलन चार्ट इज फॉर विजुअल एक्विटी. बट इट इज फॉर डिस्टेंस विजुअल एक्विटी. और जो जेगर्स चार्ट है दैट इज फॉर नियर विजुअल एक्विटी. Okay, now I have visuals of both. This is again a difficult question. It is more of ophthalmology rather than oral surgery, but since it has been asked, so we have to know. Jagger chart है इस साइड पे और इस साइड पे स्नेलन चार्ट है. तो जैगर चार्ट में if I'll just zoom out, पैराग्राफ्स लिखे हुए हैं. जैगर चार्ट में पैराग्राफ्स लिखे हुए हैं डिफरेंट फॉन्ट साइजेस में. तो पेशेंट को वो पढ़ने के लिए दे देते हैं. Alright, and that the distance which the patient can read the smallest font, उसको उससे उसका visual acuity determine करते हैं. Alright, Jagger's chart में different font sizes में paragraphs लिखे होते हैं, and patient is given that chart to read, and they determine the visual acuity by the distance from which the smallest font size can be read clearly and properly by the patient. स्नेलन चार्ट हमारा नॉर्मल आई टेस्टिंग वाला चार्ट है. डॉक्टर के पास जाते हो आई टेस्टिंग, वो आपको बिठा देता है एक चश्मा लगा के, एक बड़ा सा एक आंख डार्क कर देता है, एक आंख खुला, एंड यू आर रीडिंग दिस चार्ट. दिस इज सीन कॉमनली इन ऑल ऑफ्थल्मोलॉजी क्लिनिक्स. दिस इज योर स्नेलन चार्ट. ऑलराइट, सो ये आपका स्नेलन चार्ट है, ये वाला. Okay, got it. So with this we complete our discussion. So if there is any question, please let me know. We can discuss on the WhatsApp group, or if there are any doubts, please let me know before we wind up the session. So if there is any question that is remaining, any question that you have been able to recall, so please you can share it either on WhatsApp group. We can discuss that question, and one or two questions where we did not have a proper recall, you can help us in updating the questions. Alright, so see, we might not be able to discuss these topics. I have given a few pointers, few notes here and there. Please add them to your notes, and so that you can come back to the lecture, complete your notes, so that you have a reference for your future. Alright, so we'll wind up this session here. Thank you so much, and good night.